This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular Grand Rounds. We have one of our own, Dr. Jonathan Kim, presenting today. Jonathan is a professor of medicine and founding director of sports cardiology at Emory, and also an adjunct professor in the School of Applied Physiology at Georgia Tech. Dr. Kim attended undergrad at Emory and was a Fulbright scholar, followed by medical school at Vanderbilt, and then internal medicine peds residency at Mass General. And then he came back down to Atlanta to do his cardiology fellowship and was a chief fellow here at Emory. He's NIH funded and has built a unique research program here at ECRI, and is also the team cardiologist for major Atlanta sports teams, member of the NBA Cardiac Advisory Committee, NFL Task Force for Cardiovascular Disease, a co-medical director of the Peachtree Road Race, and also a chair of the ACC Sports Council, Sports and Exercise Council. Jonathan, thank you so much for volunteering this morning to give this presentation. I'll turn it over to you.
Well, thank you, Pooja, and it's so great to be able to present at Grand Rounds again and talk about the new ACC AHA guidelines, which came out earlier this year. And relevant, not just because I think this is an interesting topic, I suspect all of us find this arena interesting, but everybody's going to interact with athletic patients. And the way we define athletes are individuals who place a high premium on training, competition. Obviously, this includes athletes, young athletes participating in sanctioned sports, but this includes marathon runners, triathletes, people who place a high premium, again, on exercise and training. And for those of us who may be a little bit older, clearly remember the day where perhaps this is a pretty easy question, and we'll review this, where athletes who had, frankly, any sort of cardiac condition were told, oh, you know what, you just can't play competitive sports, you're just disqualified. And for those who've heard me give talks at these meetings over the last several years, certainly there's been a shift, but the guidelines were a little behind. And so we're going to review this now because it's important to understand where the changes are and perhaps when to think about referring on to a sports cardiologist. But maybe most importantly, hopefully everybody will come away from this talk recognizing that the broad stroke, you can't play sports, you shouldn't do that. Those days are are days of the past. All right, so you heard some of my disclosures. I do take care of a lot of athletes. I have relationships with a lot of athletic organizations, all of my research funding relevant to the care of athletes. So some relevant disclosures as it relates to talking about this specific topic. And here are the guidelines. They were co-published in Circ and JACC. This was in February of this year, and is an opportunity to acknowledge really what an honor it was to chair this process and work with international leaders across, of course, the US, but around the world as well, putting together these new guidelines. So I thought I'd begin, though, with just a couple cases to set the stage. And one of my personal favorite movies, I suspect for many of you listening, Back to the Future. But it's just a reminder that you don't have to go back very far to see how far we've come as it relates to how we handle these cases in 2025 going into 2026. And these are real patients, not made up, patients I took care of in these specific years. So the first, this is a 23-year-old professional football player, was a non-lineman, a skill position player, went to a non-Division One school and was not invited to the NFL Combine. For those who aren't familiar, the Combine invites roughly 300 or so high-level football players every year to Indianapolis, but many players who are drafted into the NFL actually don't participate at the Combine. At the Combine, you get a full history, an ECG, all of these things. Many schools still may not do pre-participation screening ECGs. In this case, this individual did not, so was trying to sign with our club pending his mandated screening ECG per NFL rules. And of course, you always get these and have to deal with these many times, which is a very, frankly, abnormal ECG. You don't have to be an expert in terms of interpreting athletic ECGs to recognize the diffuse infralateral T-wave inversions. And in this population, you're much more worried about a potential underlying cardiomyopathy, certainly hypertrophic cardiomyopathy. Just cutting to the chase, here's his cardiac MRI. His max wall thickness at the basal septum was about 2 centimeters. There was no evidence of any late gadolinium enhancement. So a kind of a mild HCM phenotype. He had no family history of sudden death. And of course, the question, can this individual continue on with his potential professional football career? Obviously, he completed college, probably playing with this phenotype. And if we get with the old guidelines, this is the 2015 guidelines, probably everybody remembers that it was a pretty much slam dunk, you can't play sports. So I didn't underline this, but to summarize what the authors wrote, regardless of the phenotype, individuals, athletes with ACM should not participate in most competitive sports. And this is independent of any sort of potential risk stratification, except those class 1A sports, which include golf, bowling, cricket, etc. And so this individual, unfortunately, he was told that he could no longer continue with his professional sporting career. And certainly, I remember specifically in my mind thinking, boy, this seems pretty unfair. I don't think this individual is actually really that high risk. But that was it. Of course, we know that guidelines, even for HCM, have updated there. But what about this case? So this was a year later. It's a college football player now, another non-lineman, asymptomatic, no family history of anything. And sometimes we run into these type cases where the family opted for one of these routine health screens, pay a couple $100. Let's just make sure our kid's okay to play sports. Got an ECG and an echo as a part of this. The ECG was normal. But here on the echo, you can clearly recognize that domed aortic valve, and on the short axis, pretty obvious bicuspid aortic valve. So referred on for evaluation. And again, the question, can he play college football? And that's why he was sent in to see me. These were his aortic measurements. So at the aortic root level, the max dimension was about 42 by 43 millimeters. There was no functional degeneration of the valve, but certainly probably why this was incidentally detected, as again, there was no AS, no aortic regurgitation, but he did have an associated aortopathy. So if we get with the guidelines again, the authors back in 2015 clearly acknowledged that it was not known, it's still not known, whether restricting physical activity limits the rate of aortic enlargement or the risk of dissection. And so the guidelines are very conservative. Even in that kind of mild and large range, 40 to 42 millimeters, really restricting sports into those lesser intense sports. And any sport where there's a risk of bodily contact, as you can see here, you're stuck again playing golf and crickets and billiards. And once you cross over to 43 millimeters, so up to 45, which we define as an aortic aneurysm, so even not in a truly defined aortic aneurysm, you're stuck with those 1A sports. So this individual as well was told you can't play college football. So the question, as we'll get into this talk, is actually where are the data and was this really fair, and how have the guidelines been updated now, taking into account all the changes over the years. So the most recent set of guidelines still falls within 40 years of documents in this space. This was not the first set of guidelines. Of course, I just talked about 2015, but this goes back to 1985. And many will remember the old Bethesda conference proceedings, which were updated about every 10 years. So in 1994, 2005, and then in 2015 was the first scientific statement. So that was a document that I've already referred to. So this is the second scientific statement. So the question as to why we needed this update certainly wasn't just because it's been 10 years. So let's just rehash many of the same recommendations, which certainly were included in these 4 prior iterations. But really, number one, a tremendous boom in terms of the science of sports cardiology. And a lot of studies over the last decade focused on outcomes for athletes who, even after you were told you can't play sports, chose to anyway. And so what were the outcomes for those specific conditions? And this shift in philosophical approach. And we've talked about shared decision-making in sports cardiology. Of course, this is encompassed within all of clinical medicine. But specifically in my arena, this move away from this old paternalistic paradigm, we really don't care what the data are, what your risks are. We're just going to tell you you can't play sports for a lot of underlying theoretical risk. Well, let's take a deeper dive into each of these 2 tenets. We'll start with shared decision making. And remember that shared decision making, as we all know, it's really an ethical imperative. It fits in line with the four pillars of medical ethics that we all try to adhere to, a focus on patient autonomy. In this case, the athlete deserves to have their voice heard. What do they actually want as a part of the discussion? Two, beneficence, weighing the risk benefit ratio and trying to do what's always in the best interest of that patient. Number three is the classic medical ethos of do no harm, which is non-maleficence. And then lastly, try to incorporate justice within these decisions. Now, interestingly enough, the tenets of shared decision making were recognized in the space of sports cardiology early as
we won't be able to get in the
as early as 1994, in this essay written by Ben Levine and James Stray Gunderson. Pretty unpopular, though. But now, 30 years later, of course, these tenets are recognized as important within all of medicine and certainly in sports cardiology as well. Let's talk a little bit, well, first, before we talk about some of the science, just to acknowledge that we don't have all the right answers yet. This was an essay that Neil Dickert and I wrote a couple years ago talking about the challenges of shared decision making with your competitive athletes, because we still don't have great ways to ensure that there's consistency as it relates to physicians interpreting risk and, of course, understanding how athletes interpret risk. And those challenges certainly can impact and potentially contaminate a shared decision-making discussion. So this is a really important point as it relates to future directions to refine this science. Now, in the guidelines, this updated guidelines that we wrote, we did try to pitch forth at least how to proceed or think through proceeding with this process with competitive athletes. And we separate this into three phases. The first is just being a good doctor, as we call it, making sure you have the right diagnosis and ensure that you have risk stratified that diagnosis as best possible, following general patient guidelines if available. Phase two is the most challenging part. It's certainly the part that takes the most time. If you're to engage in shared decision making with an athlete, this never fits in line with a 15-minute visit. It takes several visits. I never even talk about this with the first time I meet an athlete. We don't talk about can you play sports until later on down the line. But this is where you educate the athlete, the other stakeholders involved. You try your best to evaluate the athlete's risk tolerance, engage the other stakeholders, and then ultimately transition to phase three, which is the implementation phase. And this is either we are going to support a return to competitive sports, and if so, now we have a critical focus on the emergency action plan, which of course is that early access to AED if available, and CPR training for all who are around the athlete, and then the longitudinal clinical surveillance plan. This is never a one and done. You have to continue with that longitudinal clinical surveillance, and you of course have to re-engage with shared decision making year after year. I have certainly had athletes who initially chose to return and then over time decide, you know what, I think I want to move on to something else now for whatever personal reasons may come about. And then, of course, if the decision is to move away from competitive sports, we still want to encourage exercise. There's frankly no condition where the right answer is you should not exercise. And so we're going to come up with an individualized exercise prescription for that competitive athlete who's now retired. Well, let's talk about now some of the scientific advances as it relates to the return to sport for athletes with heart disease. And as mentioned, there's been a lot of science over the last 10 years. Here's just a handful of some of the seminal studies. For many who aren't aware, even in 2015, we began to learn that athletes with underlying long QT syndrome or athletes with defibrillators under the appropriate guidance actually were able to safely return to sport. So more prospective outcomes for those specific type of athletes, but new data for specifically individuals with hypertrophic cardiomyopathy. And then this other observational study of elite athletes with genetic heart disease conditions were recently published. Let's go through each of these studies in a little bit more detail. The LIVE HCM study was published in 2020. It was led by Rachel Lampert and Charlene Day, as well as numerous other investigators. This wasn't a competitive athlete study. They looked at individuals with HCM who either engaged in vigorous exercise or who were more sedentary. Exercise was defined by AHA physical activity guidelines, but there was a subset of competitive athletes within this cohort. But you can look at the Kaplan-Meier curve here. It was a composite adverse cardiovascular event outcome, and you can see the two curves are essentially superimposed. There's absolutely no difference whether these individuals were engaged in vigorous exercise or not. This study was more generalizable to competitive athletes. So these were 76 high-level athletes. This was an observational case series across the U.S. of several high-level centers. Emory actually was not involved in this study, but there were other major centers. These athletes all had numerous genetic heart disease conditions, most commonly long QT and hypertrophic cardiomyopathy. Over 200 athlete years of follow-up were included, and these were all individuals who, after most of these individuals being disqualified, chose to return to sport on their own with the support of these specific providers. And this was not a cherry-picked low-risk group. You can see 10% of this cohort had a prior history of cardiac arrest, and a third already had an ICD implant for some potential reason. There were 3 individuals who had an adverse event. You can see these 3 individuals here, but note only one was during exercise, and there were no deaths. So the adverse cardiovascular event rate was about 4% in this study. So clearly not zero. We certainly didn't expect this to be zero, but I would submit not prohibitive as well, and certainly supports that shared decision making is a safe and appropriate clinical management strategy in this population. Now, I wrote the accompanying editorial to this specific study and raised a couple important points as well. Again, this notion that we should be shifting to shared decision making, still not embraced across the board. This study was published in 2023. About 3/4 of this cohort were initially disqualified. And this goes back to the fact that the guidelines employed at the time all supported medical disqualification across the board. We still try to emphasize this point, and hopefully nobody thinks that we're now at this rubber stamp level where, hey, if you're a competitive athlete, doesn't matter what you have, we think you can play competitive sports. Certainly, there are high-risk features in any of these conditions that could potentially make competitive sports not safe. So we should not abrogate our duty to certainly incorporate that in a potential shared decision-making discussion. Generalizability, these are limitations specifically within this study. These were high-level competitive athletes who are professional or competed at the NCAA, now Power 4 level. What about those athletes who have less access to resources? So high school athletes, collegiate athletes at the lower D1, D2, D3 level. How should we handle shared decision making in those cases? A really important question. The potential concern for institutional bias, of course, present within this study, and we emphasize the need for outcomes data. I'm going to talk about the ORCA registry at the very end of this talk, but this is our effort to try to have more hard outcomes, understanding what the risks are for athletes who return to play with various cardiac conditions. Other landscapes have changed as well. So we've had other guidelines, the 2017 International ECG criteria. For those who don't know, we're actually updating these. These will be published later next year. The Heart Rhythm Society Arrhythmias in Athletes document was published in 2024. And non-sports guidelines, the HCM guidelines in both 2020 and 2024 really did note that this broad stroke disqualification for athletes was not the appropriate maneuver and the need to consider shared decision-making or incorporate shared decision-making within this process. Of course, we had a once-in-a-generation pandemic, so the need to consider COVID-19 and updated recommendations. But really, the rationale overall, the bottom line, is that we had an unequal playing field. The standard of care different at high-level sports cardiology centers and really oppose all of the old guidelines. So if you're an athlete unable to seek care at one of these institutions, chances are you're going to have one of these inequitable outcomes, specifically if you're diagnosed with a heart condition and you want to return to play. There may be more of that you can't play sports rather than a consideration of shared decision making. So we needed an updated clinical reference document that all providers can now reference to understand the importance of SDM, to understand that we have data to support that sports may be safer than previously believed for many of these conditions, and to try to achieve a much more of a consistent playing field across the board. So I'm going to go through some of the high-level changes within this document. Note that because, of course, I don't have all day, there are changes within every single one of these sections. So if you're interested, certainly if you encounter some of these individuals, I'd encourage you to read through this whole document, peruse through the clinical consideration tables, and really see where many of the changes exist, because some of these important changes I won't be able to cover today. But the format for this document was pretty similar to 2015. This document was separated into sections, which were comprised of expert task forces, which put forth a clinical consideration table for each of these specific sections, so encompassing the landscape of general cardiology. We did have 3 new sections in the 2025 edition. One focused on shared decision-making. I already reviewed that and talked a little bit about how we approach that, or at least suggest the approach to SDM for the competitive athlete. The master's athlete, so this is defined as an individual older than 35 who places a high premium on exercise and training. Actually never before included in one of these clinical reference documents here in the US, incorporated in European documents, but not here in the US. And then a last section, which was focused on some of these miscellaneous cardiac conditions, also some things not previously included in a sports eligibility clinical reference document. So we talk about athletes with pulmonary embolus. We talk about athletes with heart conditions who are engaged in extreme sports, such as at altitude or recreational scuba. And we actually included a healthy population, never before included, healthy, competitive pregnant athletes. And hopefully this will now lead to future documents considering this population as well. So let's go through some of the major updates, but it's also important to recognize that we had some changes in terminology as well. For those who aren't aware, you will be soon, when you review scientific statements from ACC and AHA, they have moved away from utilizing the classic class of recommendation and level of evidence. Those are only reserved for standard true clinical guideline documents. So we needed to put forth terms with their intended meaning so readers would understand what we were talking about. But we also wanted to have these terms consistent with this old terminology, again, just so readers would understand the intended meanings of these clinical consideration action items. So for class 1 recommendations where we have a high bar of evidence, either from an RCT or certainly consistent with the clinical medical standards of care, we use the term should not, can. For class 2A like recommendations where we have a high level of evidence, the term reasonable. For where there is still only expert consensus opinion, 2B type recommendations, the term can consider. And we leverage the fact that we weren't pigeonholed into 2A versus 2B because there are certain situations where you have a high level of evidence, but maybe not to the level of a 2A recommendation. So we inserted this term reasonable to consider. Now it's critical to understand that we wanted to never use the term medical disqualification throughout this entire document. We wanted to ensure that practitioners still utilize shared decision making even when in those situations where risks are probably too high. So rather than medical disqualification, we use the terms risks may or risks likely outweigh benefits. So going through some of these high-level changes, we'll begin in section 1, which was sports classification. So in past documents, sports classification was separated into very discrete panels. It was a 9-panel sports classification scheme where sports were separated by percent VO2 max for your endurance sports and percent maximal voluntary contraction for strength sports. But again, remember, there are really nuances to this. And certainly there are relative contributions during competition, and we recognize that, but we felt more appropriate to place sports on arcs now, understanding that within sports, there are differences. There are differences in terms of how hard individuals train based on level of competition, based on season. A perfect example is golf. So indeed, very little contributions of endurance and strength type efforts during competition. But as we know, for the high-level competitive golfers, these individuals train quite a bit. I call this the Tiger Woods effect. Spend a lot of time in the gym. In American football, differences in training if you're a non-lineman or a lineman. And in swimming, of course, differences in training if you're a sprinter, if you're a distance swimmer based on stroke, etc. And all of these differences should be acknowledged by a practitioner who is engaged in shared decision making and acknowledging all of these potential differences when you're talking about a potential return to sport. We talk about anticoagulation in a little bit more detail. And this is a busy figure. This is straight from the document. But we use this kind of green, yellow, red, the traffic light separation. Clearly, there are sports where if there are bodily collisions, two individuals colliding with one another, or bodily impacts, which we define as an individual colliding or running into a fixed stationary object, such as a downhill ski or crashing into a tree, there are certain sports where collisions and impacts really just aren't expected, or if they do, the velocity probably is not going to be that high. So these are the sports where it really doesn't matter what you're on, go for it. And then, of course, there are sports where Collisions and or impacts probably occur pretty regularly, and when they do, the velocity is at a bare minimum at a moderate level. Think of a boxer, American football, etc. And these are the sports where being on full anticoagulation, probably the risks likely outweigh the benefits. But as the case with many things, there certainly are uncertainties, and even in this case, there are sports which fall into a little bit of a gray zone. And I'll just highlight one sport. So I'm circling basketball. People remember the story of Chris Bosh, who was diagnosed with a condition, this is general public knowledge, where he was placed on full indefinite oral anticoagulation. He lost his NBA career. He was a Hall of Fame basketball player. But really, when you think about the sport of basketball, I would submit that bodily collisions and or impacts fall within this range. Impacts maybe not occurring that regularly, and when they do, the velocity may actually be more at a moderate level. So here we think that shared decision making may actually come into play. And it'll be very interesting over the coming years as potentially more high level competitive basketball players have this situation and how many may actually return to competitive sport. All right, this controversy of the pre-participation ECG. So this is our section where we discuss, should you incorporate a screening ECG, or is a history and physical enough? And of course, we recognize this as a controversy and debate that's existed for really a couple decades based on some data from Italy published in the early 2000s. But beyond that one study, there have never been data that have truly affirmed that screening ECGs actually save lives. What we do know, though, is when you incorporate a screening ECG, you are better. Your sensitivity is going to be significantly increased for detecting potentially relevant cardiac conditions associated with sudden cardiac arrest. So you may detect those asymptomatic wolves. You may detect that initial individual with long QT syndrome and even potentially some underlying genetic cardiomyopathies. So with that, we actually have a major change in this document relative to prior iterations. When we talk about the screening ECG, the inclusion is reasonable. So remember, that's almost a 2A type recommendation because the data support that, again, your sensitivity is much improved beyond just a history and physical. But we emphasize there have to be two critical caveats in place. Number one, you have to have the right expertise in place. One of the most dangerous things is when you have a practitioner who is interpreting the screening or overseeing a screening program, but is not familiar with the international criteria, because there are clear differences in terms of the interpretation of a ECG for a competitive athlete versus a non-athlete. And you have to have carefully thought through those downstream resources. So each individual part of the screening program has access to the referrals, to the imaging tests necessary once they have an abnormal ECG. If not, unfortunately, these are where the unintended harms based on false positives, based on forcing testing on individuals who may not be able to afford that echo, afford that referral to the sports cardiologist. Here's where potentially you can have harm introduced. There still are no data to suggest that any test beyond the screening ECG has any value, so we emphasize that screening echo, screening stress testing should not be something considered, and of course that emphasis on the effective emergency action plan. Let's take a little bit of a deeper dive here. I don't know if people out there are familiar, but unfortunately right now we do have some states that are actually passing laws to mandate screening ECGs for high school student athletes. In Florida, this has already passed. On Tuesday, actually tomorrow in Massachusetts, there's going to be a hearing for a potential bill to, again, mandate screening ECG. A bill in Nevada recently they tried to pass this bill and it was shot down at the last minute. So there are states that are trying to actually not follow what we're trying to recommend. So why is this such a danger? Well, number one, how good are the international criteria? This is a study that we cite quite often, over 11,000 UK soccer players, where they found, and this is what we generally quote, a false positive rate of about 1.5%. Well, number one, these were UK soccer players. Actually, if you look at false positive rates in different populations, you'll get very different numbers. In the National Basketball Association, false positive rates can hover around 10%, specifically for self-identified Black athletes. And even in this study, look across every single athletic ECG interpretation criteria ever put forth, and what you find are a clear disparity between false positives between self-identified Black and white athletes. Now, we still don't quite understand why we see this difference, but you can obviously see where I'm going with this now if you're mandating ECGs across the board. And I'll give you a real world example. This was a screening program I was involved with a few years ago. We had over 300 athletes a part of this program. Of course, abnormalities were either a clinical concern or if there was an abnormal ECG. Now, all the cardiologists who were interpreting ECGs were experienced, such as myself, as it relates to the interpretation of the athletic ECG. And we had 36 athletes flagged as abnormal. Every single one of these were solely due to an abnormal ECG. There are actually no symptomatic athletes. And look at the disparity here. Almost every one of these individuals were Black athletes. So again, the question as to why, we don't quite know yet. But this is where we have to consider those unintended consequences. When you mandate screening, particularly incorporating individuals who may come from under-resourced neighborhoods, you can significantly impart harm, both financial harm to the family, psychological harm, time away from sport, and potentially undue medical disqualifications. It's still very shocking to me that states are trying to put forth these type of laws, particularly in Florida, where ironically enough, they just took away the fact that you don't actually have to be immunized to go to school in Florida. But yet they're trying to mandate a screening ECG for competitive athletes. It actually really just boggles the mind. But this is something that we all need to be aware of, and in our own individual ways, need to be aware of these advocacy efforts to push back on these specific laws. Now, for genetic cardiomyopathies, as we move on, again, mentioning up front that when you think about these specific diagnoses, HCM, dilated cardiomyopathy, arrhythmogenic cardiomyopathy, we actually get rid of the term non-compaction. Non-compaction really only exists if there's an associated DCM or HCM present. But up front, this uniform approach of medical disqualification, broad stroke disqualification, should not be followed anymore. And shared decision making should be incorporated, as well as ensuring that these individuals are seen by the right practitioner. When we talk about HCM and DCM, we say competitive sports are reasonable to consider now based on some of the data that exists now as it relates to competitive sport. Now, where there is still a bit of a challenge and controversy is with arrhythmogenic cardiomyopathy, or ARVC, as referred to in the past. And these data come from Johns Hopkins. Many of you may be familiar with their study, which have shown that for individuals who are engaged in high levels of exercise, particularly endurance exercise, this seems to accelerate the malignant phenotype of both heart failure as well as malignant ventricular arrhythmias. But it's important to note that this generally involves ACM with the specific mutation in PKP2. And so we place an emphasis on gene-specific mutations, and specifically for the mutation PKP2. Here are where the risks likely outweigh benefits for competitive sports. And we emphasize that as it relates to that discussion. But for non-PKP2 ACM, or gene-elusive ACM, as we refer to this many times, competitive sports can be considered. Now, you have to have the right experts seeing this individual, of course, really providing with care and proceeding with careful risk stratification, and certainly incorporating shared decision making. And this becomes quite challenging when you think as well as a PKP2 carrier. So many times I'll see a referral, a parent diagnosed with ACM, PKP2 mutation identified. They've got a 12-year-old, 10-year-old, normal heart, but with the mutation also identified. So what can that individual do? It becomes tricky, of course, but certainly we need to ensure that we still are encouraging physical activity for this population as well. I'm not going to talk about COVID-19 in detail, but it is a nice way to segue into changes as it relates to our competitive sports considerations for acute myocarditis. For me, this date is really where the pandemic began. Many of you remember, it was crazy, right? This was the evening of March 11th, and this game between the Oklahoma City Thunder and the Utah Jazz, they pulled all the players off the court because a player for the Jazz tested positive for COVID. Soon thereafter, every major competitive sporting event was canceled, leagues were canceled, and we had to suffer through this lockdown. But with that, there was actually a lot of science specifically incorporating competitive athletes as well as COVID-19 myocarditis. Now, there are a lot of limitations with this study here, but this was the Big Ten COVID-19 registry, where every athlete in the Big Ten not only was screened post-COVID, but they also had cardiac MRIs performed. And they looked for the prevalence of COVID-19 myocarditis. Actually, it was about 2%. Now, again, there were some limitations in terms of how these studies were interpreted. But what was really interesting with this study was over time, in terms of the longitudinal follow-up, they noted that a lot of the myocardial inflammation for some of these individuals resolved in as short as a 4-week time frame. So because of the study, and this is the only study that has really looked at this, we have an upgrade in terms of how we consider clinical myocarditis for the athlete. And for those who don't know, this is an important point because regardless of what field you practice in, everybody always says 3 to 6 months, you can engage in intense exercise after the diagnosis of myocarditis. But remember, that was really made up in some of the original myocarditis guidelines, and it was never based on any sort of data taken from humans. So this study here is really the only thing out there that's available. So regardless of the limitations in the study, we state that at that 4 to 6 week time frame, as long as you have an asymptomatic athlete at that time, and you already knew that their LV function was normal, you can consider proceeding with repeat risk stratification. Of course, you have to include a cardiac MRI and look for complete resolution of myocardial inflammation and ensure that there's no provocable arrhythmias. So that's a major change within these guidelines. Of course, we also talk about COVID-19 in Section 5. And when we talk about valvular heart disease, I'm not going to go through the specific tenets of exercise-induced cardiac remodeling in this talk, but hopefully everybody's aware that if you train intensively, your heart enlarges. Many times there's eccentric enlargement of the heart, and this can certainly mask potentially early forms of pathologic severe valvular heart disease, particularly severe MR, severe AI. And that can be challenging when you have a master's athlete per se with severe MR, severe AI, and you're trying to think, is it time to intervene as it relates to fixing this valve? And this is where you have to understand the tenets of exercise-induced cardiac remodeling and have a little bit of the art of sports cardiology in terms of trying to differentiate how much of this enlargement is due to how much this individual trains or how much of this is due to the valvular heart disease that may be present. A lot of times you have to take into account volume of training and sport of choice for that individual to help make that determination. And we talk about mitral valve prolapse, but I won't get into that during this talk. Now, aortopathy, again, a little bit more organized and a little bit more in detail and advanced as it relates to previous iterations of this document. So what do we talk about? We talk about bicuspid aortopathy, hereditary thoracic aortic disease conditions, and for the first time, we talk about unexplained aortic enlargement or aortopathy in the setting of a trileaflet aortic valve. We set the line in the sand right at the definition of what we define as an aortic aneurysm within the guidelines, and that's 45 millimeters. And there's a little bit more of a liberal approach as it pertains to competitive sport for athletes with enlarged aortas short of 45 millimeters. Of course, the exception would be your hereditary thoracic aortic disease, such as Marfan, where, as you would expect, there's still a little bit more of the conservative approach here. But I would submit that we are still a little bit too conservative. This is my opinion now. But for those individuals who may have true aortic aneurysm and have a bicuspid aortic valve, as well as a trileaflet aortic valve, but the negative genetic tests and no high risk features. So why do I think we're still a little too conservative? Well, if you actually look at the data and see how common is aortic dissection within this population, what you'll find is actually pretty uncommon. So the 20-year outcome study for sudden cardiac death in the NCAA, these were published a little over a year ago, was led by Brad Pitek and Kim Harmon. And here, when we look at the registry, these are autopsy findings. Where are dissections? You can see it's a pretty rare cause. And remember, it's quite difficult to actually screen for bicuspid aortic valve. The exam or the clinical case I presented at the beginning of this talk is a perfect example of that. So we have to think about how many of these conditions are roaming around out there playing competitive sports with their bicuspid valve and potentially with aortic enlargement. And yet we just don't see that many dissections. This has also been shown in the military. This was a review over the 25 years. This was published a long time ago, actually, in about 2004, but over 6 million recruits were incorporated over 25 years. There were 130 sudden deaths included, half of which were sudden cardiac death in nature, where the dissections were absolutely zero. So we always just have to ask ourselves the question, if this is such a concerning condition to where we are disqualifying athletes, where's the proof? Where's the proof in the pudding as it relates to how risky this may be, particularly understanding how challenging it is to screen for this. The corollary would be coronary artery anomalies. We always find that as a common cause of sudden death in the athlete. It's always going to be number 2 or 3. Similarly, very hard to screen for because echo is just not as good, and the gold standard is going to be CT or MR. We're not going to be doing screening CT or MR. And yet, look how, again, rare dissections are relative to coronary artery pathology, coronary anomalies. So I believe that over the coming 10 years, as we garner outcomes, we may find even more of a liberal approach for athletes who try to play competitive sports with aortic enlargement, potentially even aneurysms. The last section I'm going to talk about is for the masters athlete. As you can imagine, we talk about very common conditions encountered in this population. I'm only going to talk about coronary disease because this is the most common cause of sudden cardiac arrest in this population. And because the recommendations and our guidelines here really diverge from the general population. So for the intermediate to high risk recreational masters athlete, we state that one can consider to proceed with potential risk stratification, including stress testing or potentially imaging of the coronary arteries. And for stable coronary disease, we actually state that one can consider utilizing shared decision-making with revascularization. So why is this so divergent from what we say or what's shown in the ischemia trial, et cetera? It is because if you look at any observational series of masters athletes, and that's the best we have in this population, as mentioned, not only do we find ischemic heart disease as the most common cause of sudden cardiac arrest and death in this population, but many times it actually is due to underlying stable disease. So we showed this in our RACER series published in 2012, where among the masters athletes who suffered SCA, these were marathons and half marathons from 2000 to 2010, stable disease was actually much more common than acute plaque rupture. So we actually, for those who aren't aware, followed this up with RACER 2. This was published in JAMA in the spring of this year, where now we actually looked at cases from 2010 to 2023, and we really look at this 23-year period as a whole. Not only is coronary artery disease is the most common cause of sudden cardiac arrest, but again, you see both plaque rupture, stable disease, and these individuals generally have more high-risk features as well. So until we have more definitive randomized control type data, certainly we have this as a 2B type recommendations where one can consider both with risk stratification, but also with potential revascularization. So these sections here, I'm not going to take a deep dive into, but if you're interested in the congenital heart disease section, we do talk about anomalous coronary arteries as well as myocardial bridging. In section 8, in arrhythmias, we ask the question, after surviving sudden cardiac arrest, can a competitive athlete return to play? The answer is maybe. As long as you, again, have the right diagnosis, appropriate treatments have been implemented, risk stratification incorporated, and of course, shared decision-making incorporated. For CPVT, there's an update as it relates to cardiac channelopathies. This is no longer an automatic disqualification again. This is something where as long as the appropriate treatments have been implemented, an athlete could potentially return to play. Clearly, this is a situation where you want to have the right practitioner seeing that individual. For sure, if I'm taking care of an athlete with CPVT, the first person I'm calling and returning the athlete to is probably Mike Ackerman at the Mayo Clinic. And then in section 11, I talked about some of the conditions that we take a deep dive into. So lastly, I just want to talk a little bit about uncertainties in the future. Certainly, we don't have all the right answers now. The aorta is a perfect example, and this is where the ORCA registry comes into play. So this stands for the Outcomes Registry for Cardiac Conditions in Athletes. As where the field really needs to go is, of course, providing more definitive and quantitative outcomes for athletes who have numerous conditions as it relates to their risk if they're re-engaged with a competitive sport. So this registry is primarily housed at Mass General and the University of Washington in Seattle. Emory is a co-site. I'm a co-investigator as a part of this registry. We currently have 260 athletes. This ranges from high school athletes all the way to professional athletes with numerous cardiac conditions. The registry's been up and running for a couple years now. Certainly, if you are taking care of high school athletes or a collegiate athlete and you think that they may be appropriate for ORCA, please reach out to me. Certainly, I can tell you the best way to refer that athlete in. We want to continue this registry across the board. Racial disparities. A passion of mine, as mentioned, as it relates to the difference in outcomes between self-identified white and Black athletes. This is a piece we wrote from our council about a year and a half ago, not only talking about differences in sudden cardiac death risk between white and black athletes, but also some of what I mentioned as it relates to differences even in ECG interpretation. We're a little behind in sports cardiology. I think many times we have not proceeded with a race conscious approach. We've had a lot of race-based medical approaches in terms of thinking about differences in risk between white and black athletes. But similar to how we think about this in the general population, I do believe that social determinants of health play a major role in terms of outcomes in this population. And it is certainly time that we incorporate these in future studies within this field. The cardiovascular care of the pediatric athlete, another important point of emphasis from our council. This is another review we wrote. Taking care of the pediatric athlete, similar to taking care of kids in general, is not the same as taking care of the adult athlete. And there are certainly differences when you think of WPW. There's differences in sudden death risk if you're 13 versus 20. And some of these certainly play an important role when you think about counseling the athlete. Shared decision making for the pediatric athlete comes with challenges as well, of course, for minors. And then lastly, I end with this because I do think this is the most important point of emphasis, and that is the emphasis on the emergency action plan. With Damar Hamlin's event from early 2023 now, can't believe we're getting close to the 2-year mark for this. There has been such an emphasis. Prior to his event and prior to his point of emphasis on this across the US, there are only 7 states in the US that had laws that required emergency action plans to be written for high schools, that coaches needed to be trained in CPR, and that AEDs needed to be within 1 to 3 minutes of all high school training facilities. But can you believe that? 7 out of 50. That's up to 29 now, I believe. So we've come a long way, but 29 out of 50 is not good enough. And with the HEARTS Act, which was published, this was right at the end of the Biden administration. This will continue to help to provide grants for schools across the U.S. to obtain AEDs. And we need to keep pitching forth these studies in the state of Georgia. We put forth, proud to have led this effort, House Bill 874, which actually mandates all schools in Georgia to have emergency action planning drills. So in the state of Georgia, there hasn't been a child to have died from a fire since the 1940s. Yet, as we all know, there are 8 fire drills that are required across the academic school years in high schools, elementary schools across the state. Why not shift a couple of those to emergency action planning drills? And that is actually in law now in the state of Georgia. And as mentioned, we have to push back on these laws, pushing for mandated ECG screening at the high school level. I cannot believe that we're shifting attention away from EAP type legislation and money for AEDs and trying to put forth legislation that could actually potentially hurt students. So I want to make sure everybody's aware of that. This will not ever happen in Georgia, thankfully, because the AHA in this state's well aware of some of what's going on, and we are already thinking about ways to push back on this in the state, but it may come about. And unfortunately, it's something that we're going to have to continue to be aware of. And then lastly, the simple message of caution. We have to be weary of this pendulum. Many times in medicine, we always kind of go overboard. And in this case, it is this idea of rubber stamping. Individuals who think, oh, I heard these new guidelines, athletes with heart disease can play sports, and just thinking anybody with any condition can play competitive sports. And of course, that is absolutely not true. Certainly, there can be times and risk present in which competitive sports is just not safe. But on the flip side, we're all aware that with shared decision making, that there are going to be future SCA cases, and there are going to be these cases, and unfortunately individuals who may die playing sports who actually proceeded with appropriate shared decision making. And we want to avoid those individuals out there who may kind of push back and say, we told you so. Shared decision making is killing athletes out there. And of course, we know that not to be the case as well. It's not about potentially preventing outcomes across the board. That will never happen. It is about doing this in the right way and trying to advocate for the athletes that we care for. Here are the individuals that were part of the writing committee. I want to acknowledge all of the collaborators as well. Many of you will recognize these names as experts in their fields around the world, and it was really all of these individuals that help put forth all of the clinical considerations that are now present. And with that, time for questions. Thank you for your attention.
Wonderful. Thank you, Jonathan, for a wonderful comprehensive review of guidelines and shared decision making, which becomes really important in some of these cases. And thank you also for staying right on time. You reviewed a lot of material. I'm going to go ahead and open it up for questions. Dr. Smith has a question.
Yeah, Jonathan, great talk. in part related to your last slide, what do you do to protect yourself from litigation? And also, how much angst do you experience in the decisions that you make, or in the discussions you have? What keeps you up at night? And particularly when things are changing. So you might have advised somebody a year or two ago on something, and then there's a change. And um, how do you deal with that? It just seems like your work in some parts, is raises concerns. Is probably not a job for everybody. So.
Great question, and Andy, indeed. I think that's an easy response too. When people always say, "Oh man, it's so cool, you get to take care of the Falcons or the Hawks." There are athletes within these teams that have heart conditions that I'm actively managing, and indeed, I lose sleep. A lot of gray hairs over the last couple years, for sure. Now, the question about the litigation, I mean, we get that all the time, and it's a really important one because, for full transparency, it has not been tested in the courts. Nobody has yet to have been sued. You obviously have to begin with very careful documentation for sure. Now, I will say a couple things. Number one, there is science out there that, and maybe not necessarily in this space, but has shown that actually shared decision making tends to reduce potential litigation across the board in certain situations. And so we're aware of that. But I also think there's a other side to this, which is now that this is actually kind of a clinical reference document, and this is as close to a guideline document as there is, one could actually come at the other side now as well. And actually for an athlete who was disqualified and not allowed to engage with shared decision making, there's a question there as well about potentially seeking counsel as it relates to, you could hear it right now, psychological harm. I wasn't allowed to play. This document, these experts are saying that this is something that one should engage in. So there's another side to this now that that's out there. But absolutely, I mean, we don't know. At some point, it may occur, it may happen out there where a practitioner is sued. Mike Ackerman actually, I asked him this question once as well, and he actually pointed out that he's more worried about the other side of this as well, which is practitioners maybe being sought after for not actually going about the risk stratification processes the right way. And so again, there's always the concern for, could you be sued in this space? It happens. There's some famous cases on the orthopedic side as well with surgeons who have been sued for outrageous amounts of money. It's just kind of the nature of the business. And I would say that, yeah, if you're going to engage in sports cardiology and you want to engage and take care of these athletes, you really have to think about that. And you want to make sure that you understand that the stakes are high, but that's also, I think, again, like, for institutions and Emory Healthcare as an example, you want to make sure you have the right people who are hired on to take care of these athletes. And that, as we look to the future of the space, I think is going to be really important, where it just can't be, hey, you want to read EKGs for the Falcons because they need this, and person who's doing it has never done it before, and they just think, well, maybe I'll get a shirt and a ticket to a game down the road. Absolutely not. The field's too complex, and it's an important part of the messaging as well.
And then just another component on that is you're also dealing, or how much are you dealing with the institution? That is, with the team, with the university, with the pros. How much pressure is put on you, and how do you mitigate that?
That's a really good point. I mean, I actually think as a team doc standpoint, that's always a question. That's part of the reason why I always put disclosures anytime I talk, is not so much just to say, look who I take care of. It's important to note that you are actually employed by some of these teams. But as it relates to kind of my experiences, I have found that, and again, I can't speak for every team out there. I have no idea, but at least for the teams I work with, a really nice separation and allowance to make decisions based on what I think is right. So I've never felt pressure for an athlete to clear them or to do anything beyond whatever they say, I think, as it relates to the risk that may or may not be present. So, absolutely. I mean, I think you could say the same for a team orthopedic surgeon. I mean, every head team doc for every major sport is getting paid by that team, and they're having to make decisions about their ACL and this, that, and the other. So it's really no different to that.
Okay, thank you. Mike Burke has a question.
Sorry, wrong button. Yeah, first of all, that was a fantastic summary of the field, John. Really well organized, very clear for all of us to understand. So I'm intrigued really how you guys dove into like the gene specific stuff for arrhythmogenic cardiomyopathy. So I guess I'm kind of curious on how far you personally would take that, because when I look at that just from a molecular genetic standpoint, PKP2 is the commonest ACM mutation. So I think we have the data just because it's more likely to be identified. PKP2 also, relative to most of the other desmosomal mutations, affects the LV less and also is lower penetrance, meaning that those folks are less likely to develop the disease from the carrier status relative to some of the other ones. But when you look at the desmosomal genes as a whole, molecularly, they all, even the TMEM43, which is an ACM mutation that's non-desmosomal, they cause the same pathophysiology in the cell where they disrupt the desmosome itself, which at least leaping forward without the data would suggest that the exercise risk would be there across the spectrum of gene mutations. I wonder how you approach that.
Yeah, no, it's a really good point, and I think in the end it was acknowledging that the literature, at least out there, just hasn't shown. And to your point, I mean, it is because PKP2 is the most common. That's just where the data are. So I personally like, again, this is why you have kind of expert genetic cardiologists and genetic cardiomyopathy experts specifically as a part of that task force. If you're asking my own personal opinion, I do and probably err more on the side of being conservative and emphasizing more of the risk, certainly as it relates to how I would counsel the same athlete with HCM, where I would feel much more confident. But for the non-PKP2s, I do feel like the risks are still more on the, in terms of that risk benefit balance, as erring more on the risk side, particularly for somebody who has that clinical phenotype. Uh, as it relates to my own personal way of having to counsel or how I would go about counseling that specific individual. So as a group, I think we just went more on the side of where's the data, where's the literature, and that's why it was given a can consider, and clearly emphasizing that you want to make sure that somebody with more expertise is a part of that management decision. So certainly here at Emory would be you. At other institutions, they have other individuals who would be a part of the management of that individual. But I agree. I mean, I just think like right now the literature just isn't there to have that same level of strength, which is why we opted to kind of leave it at that for now. And then we'll see how ORCA advances with these individuals who may or may not be a part, or just the science evolves over the next 5 to 10 years.
Thanks.
Okay, thank you. And Dr. Rab has a question.
Hey, thanks, Jonathan. What a great talk and what a great contributions to guidelines. Thank you very much. So my question is follow-up, and when do you stop following these patients? And I have patients who follow for the past 10 years with aortic roots at 4.5 centimeters. I've let them play tennis and golf. Nothing has changed. And I've done echo to 6 months and then yearly, and should I stop doing this now?
Yeah, no, great question. Now, as it relates to the older athletes, so there certainly are data, and this was anecdotal experience for years and years, but the science is out there that particularly for long-term masters endurance athletes, rowers, marathon runners, that we just see bigger aortas. 4.1, 4.2, very, very common. Now, where that line in the sand is, nobody really knows. So I always kind of draw my line in the sand at 4.5 for the masters athlete, as it relates to when I may be a little bit more kind of in depth and think about sending genetic testing. Now, that being said, actually, in my clinic on Friday, I just saw an 82-year-old who'd running marathons for 50 years. and was still highly active. And his aorta, he was referred in because aorta was 4.6. So I'm pretty sure that if we kept following these individuals for years and years, you probably actually maybe would cross over that line, 4.5, 4.6. But we just don't have kind of the data now to really know what the right practice is in terms of how often you need to track them. For my master's athletes who are in that kind of 4.1, 4.2, I at I may go years in between echoes before I would get another one, just because I believe that it is an adaptive form of aortic remodeling. And we actually published a study a few years ago. This is with Jason So, who was a fellow here, as people will remember. And we published a study. It was a small cohort, but it was a master's athlete study. And those individuals who had eccentric LVH, which is the more pronounced athletic kind of exercise-induced cardiac remodeling, also had the bigger aortas. And so it kind of makes sense, high volume load, that it would not only impact cardiac remodeling, but also potentially aortic remodeling as well. We still don't necessarily have outcomes for this. And so this is observational data that's out there as it relates to the size, but I don't think you'd find anybody that believes that there's a signal that these kind of mild aortic enlargement cases are pathologic. Now, if it's a golfer at a 4.2, I would really want to know what else they did. I mean, obviously, if it's pretty like mild physical activity and just played some golf, I don't think their 4.2, whether or not you're worried about it or not, is related to kind of their physical activity habits. So it really has to be somebody who's engaged in kind of a long history of endurance type exercise where you see that as a phenotype.
Okay.
Jonathan, Stan Sherman. I don't have the feeling about EKGs that you do. I just look at it as another reason to send them to you. It's let you go through and see what you think. But I realize there are a lot of false positives out there. But at the same time, it's just another test. It's like hearing a murmur or something else. It just, to me, it deserves further workup and at least further screening for the kids.
Yeah, no, I mean, yeah, certainly always respect your opinion, Stan, but I would say that, as it relates to the ECG, and it's in part it's the world I live in, and I see the bad outcomes, and it's a very sensitive topic. I mean, I had interacted with a lot of the advocacy groups that really push for ECG screening, and these are groups like Parent Heart Watch. I don't know if anybody out there has heard of them, or Who We Play For is another big one. And usually the organizers are unfortunately individuals who have been tragically affected by this. So I completely understand that, and nobody wants to see young people, whether you're an athlete or not, have sudden cardiac death who's healthy. But what you don't see are the other cases, because nobody's going to give attention to the individual who had an ECG performed. It was read incorrectly. They've seen two doctors. The parents aren't dead. The kid hasn't played sports for a year. They're depressed. And then even just the psychological part of telling them you're fine. Like there's real harms that can be a part of this. It's not just death. I mean, obviously that's the worst case outcome, but these type cases happen very frequently. And when you just start enforcing people to have these tests, and certainly if you had WPW and you didn't know it and you had the screening ECG and you found it, that's great. I mean, that's part of the reason why, when done appropriately, absolutely, the ECG adds beyond the H&P. But broad stroke, we're going to do this, I think. There should be no type legislation that is out there that could potentially hurt people. I think that's the bottom line. Now, of course, that's perfect world type, sentiment. But I mean, if you're going to have something out there and there's a certain sect of the population that are really going to be impacted negatively, it's just nonsense to me that should be law. I mean, this should not be a law. And that is, and actually, we are trying to write an ACC policy statement on that. It's taking a little bit of time to get this out there because we are going to see more of these state legislatures try to put these type mandates through, and it's unfortunate.
John, it's Peter Block. Can I ask you a quick question? Go back to the aorta for a second.
Yeah.
So, in structural heart disease, we deal with the proximal aorta all the time, trying to figure out how big a repair you need to do if you have a bicuspid valve, for example. Now, obviously, a lot of these athletes will not have that, but in the cardiac surgical world and in our world of structural disease, the 4.2, 4.3, we just forget about completely. We don't say that, forget, don't even worry about that. And the question now goes out to, well, okay, maybe if it's not 4.5, maybe it's 5. In fact, it may even be 5.5, as you point out. So the question is, when you deal with these athletes who have enlarged aortas and they're doing high-powered work, how often do you actually see rupture and dissection and so forth if you follow them up longer term?
Yeah, no, that's you hit my point on the head there, Peter. And I was kind of showing the data. I mean, thank God I have not personally had an athlete I've cared for have an aortic dissection in this case. I will tell you, I have two athletes, very high level athletes that I managed, both of them had aortas around 4.8. And none of them with kind of a high risk mutation identified. And does that give me angst and gray hairs and worried about it? Yeah, it does a little bit, but at the same time, I just don't think the literature or the data that exists, the outcome studies that exist, support that these type individuals are dropping like flies. Now, Alan Braverman, who many of you know is one of the worldwide experts in Marfan, who's at WashU, I mean, I don't respect anyone more than that guy, and he's part of the reason why we're still a little bit more restrictive as it relates to these guidelines, because in his practice he sees so many of these young folks, and he says in generally they're usually present with dissection. I kind of wonder sometimes, given that he is a Marfan clinic, that how much selection bias may be present to what he's seeing versus all of the potential folks out there that never get to his clinic. But I just think that if if this were as significant a problem as we kind of make it out to be as it relates to sports restrictions, we would just see more dissections because you don't screen for these conditions. So I feel like these conditions are kind of like where HCM was about a decade ago. My opinion that 10 years from now, we may be even more liberal with aortas, and maybe our line in the sand will be 5. That's been kind of my own personal line in the sand. No data to support that, but at 5 centimeters is where I do kind of say, okay, that's it. I'm not comfortable anymore. But who knows? But at that 4.5 to 4.9 level, I just wonder if we are still a little too restrictive.
So one quickie to follow up. So if these folks come in with a 5.5 or 6, and you say it needs to be repaired, can they go back to playing high-level athletics if they have a proximal prosthesis?
I think so. There's some data actually from Dr. Braverman's clinic where they followed some high-level masters athletes. These were bicuspid aortopathies that all got repaired, and they actually went back. I know of at least one professional athlete. I actually think this is public knowledge, but I won't say the name, who had big aorta repair and went back to the NBA. There's not been anybody in the NFL, to my knowledge, that has ever had aortic surgery, but I kind of think it's a matter of time, and I do think they can go back.
Thank you.
Any other questions or comments? All right, great. Thank you again, Jonathan. Fantastic review, and I really appreciate all the discussion and questions that everybody had. Thank you, and I'll see everyone next week.
The preceding program is copyrighted by Emory University.